This is Dula Sizwe Simelane on the Morning Brief.
6 minutes to 7 on this Friday. A coalition of healthcare professionals has proposed an alternative to the country's national health insurance system. The healthcare practitioners argue that the NHI is unworkable and destined for failure. Under the name Universal Healthcare Access Coalition, the group has suggested a set of structural reforms that aim to improve public health care quality and reduce the rising costs of medical aid schemes. Let's speak now to Professor Alex van den Heever, who is the Universal Healthcare Access Coalition Steering Committee member. Good morning to you, Prof, and thank you for your time. Before we get into the details of your proposals, you move, if I understand correctly, you move from the premise that as it is now, the national health insurance is simply unworkable and bound to fail. Why is that?
Well, it requires that you shut down both the provincial health system and the medical scheme system and collapse it into a single national fund so that our universal coverage, or everybody's cover that is kind of guaranteed, will be provided by one tax-funded organization. So this is not regarded as feasible because there's no way in which our current expenditure will all be raised on healthcare is going to be raised by national taxes. Taxes are already, government is already at tax capacity, which means that if it increases taxes any further, it's actually going to reduce government revenue. So there's a ceiling on how much can be raised from taxation. So you cannot have a health system based in which the guaranteed healthcare that people have is provided entirely through a tax-funded system.
But the Minister of Health, Aaron Motsoaledi, denies that the NHI will have the effect of collapsing private healthcare medical aid schemes. He says actually there'll be complementarity because currently there are many areas of healthcare that the medical schemes don't cover, and it will be that coexistence that says, you know, there's no duplication of coverage and functions.
So that's not what he's being saying. It's not what the white paper has said. It's not what the intention of the framework was. It was to essentially say whatever is covered by the National Health Insurance Fund cannot be covered by a medical scheme. So that if you cover cancer treatment or oncology in the National Health Insurance framework, then medical schemes are not allowed to cover it. So essentially, pretty much everything that is regarded as quite crucial for coverage will not be possible through a medical scheme, and you'll have to get it through the state. So
tax-funded versus contributory insurance systems, how would that work under your proposals?
So essentially, we already have a pre-existing framework which incorporates both. But the problem is that in both of those sectors, both systems, there are weaknesses that need to be addressed. Now, these are well known. They have been identified now over many, many years in government reports, in official processes, including the private sector, the health market inquiry, which took 5 years. Not one of the reforms that are required to stabilize the private system have been implemented. Not one of the requirements to stabilize the public system have been introduced. They're proposing to rip up the provincial departments and basically centralize the funding of and purchasing of healthcare at the national level of government. You don't need to do that. We need to basically stop the corruption at the provincial level, which is really a governance reform. It's not an architectural reform in the system. So we're proposing in both environments and the reforms that are necessary to get both of these systems to start working effectively and to harmonize between the two of them.
And among the proposals that I found quite interesting, you're talking about high income groups being compelled to pay contributory insurance through medical aid schemes. How do you envisage that working?
So in essence, why that is a proposal is for a certain group of people, you don't want to have the option that they adopt, because you will have to have free public health care. You might not be aware that public services are not actually universally free. There's a means test. So the higher income groups are effectively excluded from access to free public health care. They have to pay for it. And medical scheme members have to pay for it through their medical schemes. So the issue is really to retain the requirement that medical schemes pay for public services through their medical scheme. And what you don't want is when you've declared basically public sector services free, that you don't want people, if the services improve in the public sector, to just opt out of their contributory regime and move into the state. That's called anti-selection. So what you do is you compel them to be on a medical scheme, and if they use the public sector, then the medical scheme will pay for it because it's not really funded for them. So the issue is really to make sure that you don't have this unpredictable movement of people, a buy down into the state. That's typically why you'll have this structural intervention. And so it's necessary to preserve both the integrity of the medical scheme system and the financial position of the public sector.
All right, I've got to thank you for your time and your insights this morning. That's Professor Alex van den Heever, who is the Universal Healthcare Access Coalition Steering Committee members.